Welcome everybody to the Care Groups Forward Interest Group meeting for November 12, 2015. My name is Mary D. Coster. I'm the top senior specialist for social and behavioral change programs. We're excited to have a wonderful presentation today from Feed the Children and Hesperian. But first, while people are still gathering.
Yeah, do you want people to activate their microphones?
Normally,
I could walk them through that if
you introduce themselves. This is a large group of participants, so we may have to kind of move through the list quickly. Do people have microphones so they could introduce themselves? Probably, actually, it'll be better in this case. I see we've got 17 participants. It'd be better if people. Hello, Patrick? Go ahead. That's a tough call. Let's see, because it's a big group. No, I think we'd better skip it. It would take like 20 minutes to get through the list of participants. Usually we're a bit smaller, but I think this topic has been a good draw. So unfortunately, we're going to skip. So Tom Davis, Chief Program Officer with Feed the Children, waiting to see if he got funded for a trial of interpersonal therapy for groups to reduce depression in a big care group project in Malawi. Erica Keatron from Land of Lakes, I hope I got that right, supporting a Title II program in Madagascar. Alan from World Review Bangladesh. Kohima Dairy. Stephen Levy, SBC Technical Advisor at USAID. Welcome, Steve. Oh, Stephanie, sorry. Stephanie Levy, I need to read more carefully. Jennifer Marcy, Jean Capps, this is going by fast. Suzanne Furman, Emma Sachs, Altrina Mucuria. Yemisi, who just joined TOPS. Clementina, who's one of the presenters today. So actually, now, Mary Helen, welcome. Matthias Pollock, who's just started with PSI recently, I think, looking at wash nutrition linkages. People are doing a great job typing quickly. Okay, and now that it's I see a couple more people are typing. Sarah Bowler. Hi, Sarah. Working on a final evaluation for an RCT that they conducted in the DRC, measuring added value of using flip charts plus films. Lauren Galvin, coordinator at PCI, supports RMNCH, gender and HIV programs, supporting implementation of care groups in Malawi. Okay, should we take 2 more minutes for this? I see Lonnie Crane, Aaron Pfeiffer, Laura Altabelli. If I'm making a hash of people's names, please forgive me. Okay, so now let's move ahead. So our agenda today is not complicated. Our presenters, got numerous presenters, Cindy Fitzenmeyer, Clementina, Bill Moses, and I think Sarah, somebody from Hesperian. They'll introduce themselves as they go, sorry guys, and then we'll spend a little time on announcements and updates. So who's going to take the mic first for the Feed the Children / Hesperian presentation. Is that you, Cindy?
I have it, Mary. Thank you. Yeah. And thank you, everyone. Good morning. Thanks for joining. It's great to see such a wonderful group and interest in today's presentation. So we're fortunate to have many presenters to discuss this project with us. We're all sharing one presentation, so hopefully that will help with the flow of the webinar. So as Mary said, we have 3 colleagues from Feed the Children. Clementina Ngina is joining us from Kenya, so we're very grateful to have her at 9 p.m. her time. Phil Moses and myself, Cindy Fitzenmeyer, from Feed the Children U.S. office. And then 2 colleagues from Hesperian Health Guides, Sarah Shannon and Kathleen Tandy. So, sorry, I realize I have to switch my slides. Here we go. So to give you a brief outline of the presentation, first I'll provide an update on the effectiveness data on care groups. And for those of you who joined the SBC Journal Working Club webinar last week, this will be a little bit of a review, but we just thought it was important to talk briefly on the effectiveness of care groups. Next, I'll turn it over to Clementina, and she will introduce Feed the Children's Care Group Project in Kagera, Kenya. And then we'll have Phil Moses and Hesperian will talk about the collaboration between Feed the Children and Hesperian Health Guides on the development of the curriculum for this particular Essential Hygiene Actions module. And Phil will also talk about the incorporation of formative research results, specifically the barrier analysis. And then I'll spend a little bit of time talking about one particular lesson in the module, which is addressing environmental enteropathy, or baby wash. And then we'll conclude with questions and answers and a discussion session. And as we go along, feel free to write questions in the chat box, and we'll take questions at the end, I think. Okay, so, sorry, switching slides. Okay. So this first slide is demonstrating a study that was recently published by Tom Davis and others, which compared the effectiveness of care group projects conducted in 5 African and Asian countries to other USAID-funded child survival projects in terms of coverage of key child survival interventions and under-5 mortality. In this study, they looked at 10 care group projects and 9 non-care group projects. And these projects were matched by country and year of program implementation for comparison. In this graph, you can see that the care group projects, shown in light blue, outperformed the non-care group projects, which are shown in dark blue, on every indicator in the analysis. And the indicators are listed along the x-axis, and the y has the percent change. And those little numbers at the top are showing the number of programs that looked at that particular indicator. So overall, in the care group project area, coverage increases were more than double than those in non-care group project areas for all of these high-impact child survival interventions. And these differences were statistically significant. If you missed the webinar last week, for more details on the project, we have the link here on the slide, and we can post it in the chat box for you. And then one more slide on this study is to just show, more importantly, that the rate of decline of the estimated under-5 mortality for care group projects was 53% greater than for non-care group projects. So again, the care group is in the light blue, and the dark blue are the non-care group projects. And so we just want you to keep in mind that these comparisons of care group versus non-care group projects were done in same countries at roughly the same time period, and they used the same funding source where the maximum funding level was fixed. So it's a pretty robust evidence that the care group approach is outperforming other approaches to change behavior and lower child death. And now I'm going to turn it over to my colleague Clementina. There's a bit of a delay, so it may take her a few minutes here, but we'll turn it over to her.
Hi everyone. My name's Clementina Ngina, working for Feed the Children office in Kenya, managing the nutrition pillar. So in Kenya, we are implementing the care group approach, and we are in Nairobi County, in a sub-county called Langata, and we are focusing the project in 3 villages. We call them community units. That's Kambimuru, Kisumu Ndogo, and Lindi. When you look on your right, you can see the map of Kenya and where Nairobi is placed. You can further look and see the slums in Nairobi. So we are among the 3 areas within the slum. And our target population is pregnant women and mothers of children less than 5 years. The project timelines are from January 2015 to January 2018. And we are looking at 3 results areas. That's improved essential hygiene actions, improved essential nutrition actions, and also improved health-seeking behaviors. That's antenatal care, postnatal care, and family planning. Just to give the current project process, we started way back last year, and we've been having sensitization meetings at different levels. At the national levels in Kenya, we have a national technical working groups. We have the maternal, infant, and young child nutrition working group, as well as the steering committee for maternal, infant, and young child nutrition. At the community strategy national level, we have a national community strategy working group. So we sensitize the members of those working groups at the national level on the approach we are going to use in our implementation. We also targeted the county where we are implementing, Nairobi County. And we sensitized the County Health Management Committee, and this was done in November last year. We also went further and did some sensitization of the sub-county health management team so that they understand clearly the kind of approach we'll be using in our implementation. And early this year, we also did sensitize the community, and this included the gatekeepers as well as political leaders. This we were doing in collaboration with the Ministry of Health. We also did capacity building sessions. We were taken through the care group approach, the care group model, and during the training, we ensured that we had Ministry of Health representation from all the levels, from the national, from the county, and from the sub-county. We also did a regional training on knowledge, practice, and coverage, whereby we were taken through the LQAS and the cluster sampling methodology. And we also did a training on designing for behavior change and barrier analysis, and we still ensured that we had representation from the Ministry of Health, since we wanted to walk this journey with them for them to understand clearly the kind of implementation we'll be focusing on. For the essential hygiene model, we are to start the behavior promotion this month of November, and we are happy to have the experience given us the final work, and it is ready to go for printing. And lastly, we'll be having the community behavior promotions starting this November. And we are going to ensure that the neighbor group women, the sensitization, the behavior promotion begin this particular month. Just to continue, we also did activities before we started. We started by doing household mapping and registration in the project area. And this we are doing because it's before we could form the care groups, we had to know to do the mapping, and we did form community units, and we were able to know in terms of the mothers we are targeting, how many mothers fall within our implementation area, and these we are able to do in the month of February and August, and we did together with the Ministry of Health. We also did a baseline survey using the KPC methodology, This was done in July this year, and we also did a barrier analysis where the results of the barrier analysis were used to inform the work the Hesperians have done on the essential hygiene actions. We'll be doing many knowledge practice and coverage surveys twice a year after we are through with the model training, so after we are through with the behavior promotion, and we'll do the final knowledge practice and coverage evaluation at the end of the project. The development of the curriculum and the models are still ongoing. However, we've already received the essential hygiene action ready to start the behavior promotion. And as I said, the behavior promotion...
Yeah, this is Phil. Clementina, we're having a little trouble hearing you. If it's okay with everybody and with you, Clementina, I'll go ahead and take over if that's okay. I'm sorry. Could we start with the next slide, please? Hey, oh, one back. There you go. Okay. This is a photo of one of the neighborhood women's groups sites in Quivira slum. Quivira is very crowded. And you can see that the fellow on the far right there is one of our promoters. The lady on the left with the striped shirt and the girl with the pretty hair is one of our care group volunteers or leader mothers. You can see this is a long corridor with about 10 homes opening up into that corridor, this little compound. So that care group is a combination of the mothers in that compound and the compound next door. Together they make about 10 moms with little kids. Next slide, please. Okay, and this is just a shot of what some of the distinctions between an urban setting and a rural setting. This module really focuses on the essential hygiene actions, water, of which figures very importantly in that. And in Quivira, as in many urban areas, the water comes from these little water kiosks, little standpipes that you pay 10 shillings for a jerry can of water. So the water is there, but you pay for it. So that's just a distinction between what you often find in rural areas. Can we have the next slide, please? Okay. Now, Clementina, I'll try to do justice to what you were saying yesterday, but we're just beginning this project, so based on some of our initial experience and feedback from the field, these are some of the issues that we understand as very probably are looking to encounter here in our project in an urban setting. First off, in Quivira, anyway, it's hard to find good places to meet. It's a crowded urban slum. There's a lot of background noise, a lot of distractions. Finding good meeting times has been an issue. Almost all of the mothers work outside the home. In rural areas, women are working all the time. Yes, but they're working. You tend to often be working from home. So we've had to shift some of the meeting times for the weekends, which is a little harder in terms of our own personnel moving them around, but it's working so far. It's also hard to maintain the proper composition of the group and a manageable group size. Care group meetings and neighbor circle meetings are held sort of in the open. And so when people see and want to attend, they sort of step in. There's no way to keep them out. Sometimes that's not an issue, that other people come and hang out and listen, but often it's a problem because if we're talking about sensitive issues and there are husbands there, that might chill some of the discussion. Also, so there's some pedagogical issues. Once you start having a larger group, it gets more difficult. Turnover of beneficiaries is anticipated to be higher in this urban area than you would normally find in a rural area, both among the beneficiaries and the leader mothers and the care group volunteers. Now, we do see a fair amount of migration around, people moving house, but from the most part, what we can tell is people tend to stay close by. They just move from one house to another house a couple blocks away. So we are anticipating that as people move, a lot of them will move into a different part of the same sector where they can be integrated into another neighborhood group. Also, coming out of our most recent, our baseline KPC survey and discussions with some of the mothers, we have reason to believe that the stress levels and the depression levels are higher than we might find in other parts of the country. It's this, people don't necessarily have the same kind of support groups they have in a rural area, and we suspect, at least from what people are telling us, we're seeing a very high level of women reporting that they've been victims of gender-based violence. Now, some of the possible advantages we're looking at are transportation is easy. This is a very crowded slum. We don't have to buy vehicles. We don't have to, have motorcycles. Promoters don't need transport. They can walk around wherever they need to go. We don't encourage this, but if mothers do miss a meeting with their care group volunteer, more often than not, she can walk half a block down the street and go to a different meeting nearby. Mostly people know each other. Now, most of the volunteers are literate in this urban setting, so it makes the teaching a lot easier, and many of the mothers are literate as well. And the other thing is that the cell communication, mobile phone communication is very good. This is right smack in the middle of Nairobi. So promoters can call up the care group volunteers and leader mothers easily, find out if they're not at the meeting, they can call them up, say, where are you? It's very easy. Let's go ahead and switch to the next slide, please. Now, what I'd like to do now is look at some of, just to give you a little bit of an overview of a picture of what we're trying to accomplish with this module, why and how we partnered with the Hesperian Health Guides to develop the module, and then describe a couple of examples of how we incorporated formative research findings into the module. So at Feed the Children, we're shifting focus of our programs from one that historically has focused on, maybe predominantly on school meals and school-age children, to a focus on community-based social behavior change to combat stunting, with a very strong emphasis on attention in those first 1,000 days of life. The care groups methodology was the best fit for our fields. So we wanted to help each of our teams start up a small care groups project. Now, the problem facing us was that while the Kenya team had a lot of experience in maternal and child nutrition, care groups was a completely new methodology for them. What's more, our teams in Uganda and Tanzania had no real experience in maternal and child nutrition. So we needed to make this initial phase easier on our teams by developing one module with a generic set of images that could be used across our different countries in both urban and rural settings, with a minimum of changes to the images. This module would be kind of a starter set. And we also wanted the images to be black and white line drawings so that each country could adapt them more easily to their context. So that's when we sought out Hesperian to help to see how they could help us, and we were quite happy with what they've done. So go to the next slide, please. Thank you. So just really briefly, this is the process that we went through to develop the curriculum. We developed a draft curriculum here at headquarters with a lot of help from the Kenya staff. We conducted formative research, as Clementina mentioned, the barrier analysis in Kenya. We engaged Hesperian to develop the initial draft images. A lot of back and forth with that. They were extremely helpful and gave us lots of guidance. We field tested the messages and the image. Now, Hesperian helped us with a lot of guidance on how they do their field tests, which is very helpful. And the Kenya team did an excellent job of actually doing the tests and bringing us back the feedback. And then the final step was we incorporated the findings into the final images and text, which sounds a lot more easy than it was. But the Hesperian folks were very used to this, and they managed it very, very easily. So what I wanted to do is really quickly give you a couple examples of how we integrated the barrier analysis findings of formative research into the curriculum. Now, in January of 2015, we conducted a barrier analysis on 2 behaviors. One of them was making sure that the children 0 to 23 months old drank only treated water. Actually, it was 6 to 23 months old. When we compared responses of the doers and the non-doers, we found that the doers were 1.5 times more likely than the non-doers to say that their child's grandmother approved of them giving her baby treated water. This was and the difference was powerful. It was statistically significant. So this is what you see here is basically lifted from our Designing for Behavior Change framework, which we developed. So we decided that our bridge to the activity should be to enhance the perception that grandmothers actually do approve of this behavior. And we considered a few different activities, but we decided the best thing to do would be to include in the lesson plan a story of a grandmother encouraging her daughter to only give treated water to the baby. And we created the story and talked it through Hesperian and worked with them, and they helped us to create an image that would convey this approval. So let's go see the next slide, please. So this is the image that we came up with. That really Hesperian put together for us after lots of discussions. So the main character, Halima, is there with her baby on her lap, giving her treated water. On the left-hand side, you see a little bitty bottle of WaterGuard, of chlorine for treating the water. And on the far left side is the grandmother, and in the middle is Halima's friend, Constance. So we thought it would be good to, because we heard from different sectors that a lot of other people said, oh, our friends or our neighbors approve of this kind of work, or this kind of practice of giving a child treated water. We wanted to include have an image that included approval, or that portrayed approval from both the grandmother and from friends. Let's go to the next slide, please. So this is a shot of another piece of our DBC framework. And what we found is in this urban setting, it's very common for mothers to leave their babies with a caretaker during the day while the mom goes into town to work. Now, in some cases, these are more formal or official daycare centers, but for the most part, these are an informal set up in somebody's home. So the barrier analysis revealed that the people that treat their child's water were 1.7 times more likely than non-doers to perceive that it is difficult for them to ensure that their children only drink treated water when they're with a caretaker in daycare. And this was also a statistically significant change or difference. So it has to make sense, because this is a barrier that you might not encounter until you actually try to do it. The non-doers really didn't mention it because they hadn't tried. So we decided that the bridge to activity here would be to increase the perception that children can drink treated water even when they're with a caretaker. So we came up with a number of program activities to achieve this, including having discussions with the caretakers themselves to find out their perceived barriers to making sure that their charges only drank treated water, maybe train the caretakers on proper hand washing treatment, etc. Now, for the care group's curriculum, we decided that we needed to address this in the lesson plan on managing water in the household with a corresponding image. So again, here you see the image of that we're able to put together that shows the mom giving her, the caregiver, a little bag with some treated water in a bottle, which we found, which we were told earlier, was a very common practice. So that's what we decided to use and to incorporate into this particular part of the curriculum. Now, with that, I'd like to ask Sarah, Kathleen, and Alex, thanks so much for coming, to jump in and talk a little bit about the work that's been done from your end and the kind of work that you do in general. Thanks.
Thanks. So this is Sarah Shannon. Hi, and I'm the executive director of Hesperian, and I'm excited to talk a little bit about this collaboration today. It's exciting in a number of ways, and I guess one of the things that we're particularly intrigued about is the idea of developing messages that are really replicable, both in urban and rural settings. I think this is increasingly a challenge for those of us doing community-based primary health care. So just a little bit of background about Hesperian for those of you that aren't familiar with our work. We're Berkeley-based. We have more than 40 years of developing community-based materials. Our flagship book is Where There Is No Doctor, but if you've seen us at core group meetings, you're aware that we work on many other topics and issues, ranging from nutrition, water and sanitation, sustainable agriculture, occupational health, maternal child health, women's health, NCDs. It's a huge range of things. And again, our materials are in over 80 languages. And one of the things that we are really known for are the iconic images, line drawings that are accessible and that work together with the text to convey messages. Go ahead and advance the thing. So a little bit of background about how we approach our work. And again, really the idea of thinking about images, illustrations, and text working together to effectively convey messages that bring health information out of the clinic and to the community. We work really hard to ensure that everything that we develop, both images and messages, are culturally appropriate, that they're easy to understand, visually engaging. One thing that we definitely share in common with Feed the Children is a commitment to modeling positive behavior. And the way that we develop all of our materials is collaboratively with partners. So we're very practiced at partnering with 10, 20 organizations working on a single piece of new material. So we've developed a lot of kind of processes that facilitate collaborative work around developing materials. So specifically, in this collaboration, we were really excited to work with Feed the Children on a care group module. This was new for us and something that I want to emphasize we learned a great deal about and from as well. The areas that we provided support in this case were around helping Feed the Children think about the process for developing the images and the working on the modules in terms of incorporating those images. We worked with them in terms of thinking about the kind of image and the art conceptualization, which my colleague Kathleen's going to speak a little bit more about, creating those original images, and then the production design support as well. And as Phil mentioned, and I'll talk a little bit more about in a minute, we also worked carefully with Feed the Children to develop and support the process to field test those images and the modules. So Kathleen Tandy, you want to just introduce, is our production designer, and she worked very closely with Feed the Children on this project, and she's going to explain a little bit about some of the details.
Yeah, so I'll give you the nitty-gritty. What we did is we created 76 original images that went into 90 pages of lessons. Those were 6 different lesson plans, which then were accompanied by flip charts, which totaled 23 pages. I worked directly with Phil and the illustrator, and because we had a really good process of communication, asking questions when necessary, commenting when we felt it was appropriate, we only had 1 or 2 revisions per image, which is pretty unusual when you're working with an illustrator. And part of the reason that we were able to do this is because our illustrators are pretty aware of the kinds of conditions that we're trying to illustrate. We work with people all over the world. Most of our editorial staff, as well as myself, have traveled in Latin America. I've traveled in Latin America, the Middle East. Other folks have traveled in Africa. So we are really aware of what village life is like, what an urban slum is like, and that makes our work more efficient. I'll just comment on a couple of the images shown here. What our philosophy is about images is that the images should drive the narrative. We don't just illustrate a scenario. We try to give the before and after in the illustration. So if you look at the image on the top right, we were trying to illustrate that before you pick up a newborn, you should wash your hands. And I think the illustration kind of says that without words. You kind of get it right away. The same can be said of the illustration of the woman washing the vegetables. There's the little bottle of WaterGuard right there. So you get it right away. It's not just washing in any kind of water. You're washing in treated water. And we're going to talk about field testing a little bit later, but I wanted to say that the bottom right image was changed as a result of the field testing process. Initially, we had envisioned the WaterGuard seller having a little cart, but then the folks in Kenya let us know that, well, actually in Kibera, that's not the typical situation. Usually they sell out of little shops that also sell other products. I guess that's it for me. I'm going to turn it back over to Sarah.
So, I think one of the noteworthy things about this project is that we were working with Feed the Children to develop a significant number of new illustrations. And those illustrations needed to work in multiple settings and contexts. That's something that we strive to do when we're developing materials. And so one way that we ensure that that works is through field testing. And so we really encourage Feed the Children to field test these images along with the rest of the module, obviously. And the reason that we believe that field testing is really important is because you do want to make sure that the message is very clear, that it's communicating what you want, that it's being read, understood in different settings, and of course that it's respectful and positive, and that it's really doing the job that it needs to. So one of the things that, and we really think that field testing is a critical part of any kind of materials development. We shared guidelines about how we field test images with Feed the Children, and then supported them to adapt those guidelines and have them work with their staff with the idea that this would be a capacity building process for the staff so that future modules could be field tested with greater ease, and it could just be an activity that's incorporated into future work. There's a before and after on this slide that I'm actually going to ask Phil to describe a little bit more in detail about, because at first glance the changes look fairly subtle, but they're actually really key changes that make a difference in terms of this image being effective.
Okay, sure. Did you want me to talk now?
Yeah, sure.
Okay, sure, yeah. Well, first off, I just have to apologize. This actually is a co-production of Feed the Children, Hesperian, and Food for the Hungry. We talked with Food for the Hungry, and a lot of the content is based on one of their modules that they developed, that Mitzi handled, and the others developed. So we should have said that straight up. I really apologize about that. A lot of the content came straight out of that module. We added a lot, especially the lesson number 6, and all the process that we just described are the ways that we contextualized it to our needs. So with that aside, let me talk just real briefly about this field testing. If you look on the left-hand side, you see the rough sketch of this is what we thought. Okay, the mother showing her caretaker, in this case the grandmother or an older woman, how to wash the baby's hands while she's away at work, right? And so when we field tested it, we got 2 big important things that came back. One is they said, it looks like that this mother is scolding or sort of about to hit the lady, and that stance is not a good stance for someone who's trying to learn. And so to convey the message of learning. So, change how she's standing, change the position of her hand. So if you look on the left-hand side, she's got her hands kind of over her mouth like, oh, I see what's going on. And the other important thing they mentioned is that these houses are tiny. So most people who have a hand washing station, and many do, have them behind the front door. So put it behind the front door. And that way it will look a lot like, physically like what people use a lot, and also the interaction that you are portraying will be much more understandable and respectful. So that's about it.
Great, thanks. And that's And I think also I think the other thing that putting the door in really models as well how you can fit that leaky tin, that's what they're called, leaky tin setup in a confined small space. And so there was like a lot of different messages being conveyed with this image, and that feedback really helped make that happen. Next slide. Yeah. So briefly, I did just want to say that, you know, we are increasingly trying to partner with other organizations on projects like these. And so since many of you work on this kind of material, let me just say briefly that, you know, we are interested in exploring partnership. Some of the things that we bring to this include, because of our experience in materials development, a lot of knowledge about how to make a process efficient while also generating really effective products. We do offer a wide range of services. In this case, the partnership with Feed the Children was pretty expansive in terms of developing totally new art as well as the other support that we described. In other cases, we've worked with folks where we've instead adapted existing images or helped them repurpose or edit existing images. So in many ways, you know, it depends a lot on what your goals are and what your needs are. And that range of services can include editing as well as just images, production, and design. I think this particular partnership really illustrated a pretty wide range of our activities. And in our experience partnering with organizations on projects like these so far, you know, depending on the range of services, it's anywhere from 5,000 to 25,000, and it just is totally variable. And we really approach it based on, you know, what is the least amount of cost to get the product that you need. I think as we've tried to emphasize, we really do bring a collaborative framework and a lot of experience on how to collaborate with partnerships and with partners. So that's another thing that is just sort of inherent in our work process, and one that I think makes you know, us a good group to partner with in that sense. So, you know, Alex and I are happy to speak afterwards with any of you all about exploring other ways to work together. I think, Cindy, you're on?
Great. Is that your last slide, or is Cindy next?
I think Cindy.
I'm next. Yeah.
Okay, go Cindy.
Okay. Thanks, Sarah and Kathleen. Yes, our experience at Feed the Children working with Hesperian has been extremely positive and very easy, very collaborative, and so we've really enjoyed and appreciated this partnership. The next few slides, we just wanted to take a few minutes to focus on Lesson 6. Essential hygiene actions are common. We in the care group world have modules that address those topics and those actions. But as far as we know at Feed the Children, this is the first time that in a care group project we've attempted to incorporate research and lessons learned around environmental enteropathy. We do know that a project in Ethiopia as well as Zimbabwe are looking at this topic and teaching on it, but we weren't able to get a hold of any of those materials. So it's something that we would like to talk about in the discussion if any of you have experience in this or have attempted to do this. So the way I want to do this is just go over our objectives and then show the corresponding pictures that kind of align with that particular objective for this lesson. So the purpose of this lesson is to reduce environmental enteropathy as a means of preventing stunting. We know that babies and small children who live in poor sanitary conditions are much more likely to become stunted than children who live in good sanitary conditions. And there's a lot of discussion on this lately, and we won't go into too much detail on the ins and outs of the topic, but just wanted you to know where this is coming from. So our first objective here in our Healthy Play Area lesson is that caregivers will provide a play space for children under 2 years old that is a clean mat for children to play on to prevent them from eating soil or feces. And so then if we look at the pictures, yes, here we go. So we see two pictures here of good practices of clean, safe play spaces. So on the left, you see a mother sitting at a table, and she is between the baby and the cook stove that's behind her. She's actively watching the child as she prepares some food, so she's keeping her eye on the child and engaging the child. And then if you look through the door, you see the chickens are in a pen outside. And we know that chicken feces contain more harmful germs and bacteria than from other animals. So it's especially important to keep chickens away from small children. And as we know in the places we work, chickens are a very common small animal that households have. And just a little bit, we know that swallowing germs from feces irritates the intestines of small children. And so when this happens, their intestines may not absorb as many nutrients from the food they eat, and that thus is a contributing factor to stunting. And then on the right-hand side, you see a child sitting on a clean play mat. Here we're recommending a kind of like a plasticated fabric. It's similar to a blue tarp you might see at a hardware store here in the States. And we wanted the tarp to be smooth and washable, so you could wash it with soap and water, but we didn't want it to be too thin that it could cause a suffocation risk. So you want something that's a little thicker than just a thin piece of plastic. So this is what the images that Hesperian helped us develop for this objective. And so now we'll look at the next three objectives kind of corresponded to similar images. So I just wanted to go over all of these here at once. So our objective 2 is that caregivers will clean and sanitize the playmat once a week and whenever it is soiled with food or dirt. The third one, caregivers will clean and sanitize toys and other items that babies frequently stick in their mouth at least 2 or 3 times per week, and each time you notice that they are soiled with food or dirt, when the baby is recovering from an illness, and when other children have put the items in their mouth. And the fourth objective, when caregivers leave their child at a daycare center, they will encourage the caretakers to use clean mats and to clean and sanitize mats and toys regularly. And for Kibera slum, this one is really important. As Phil mentioned earlier, many of the mothers are going to work away from the home, so they're leaving their children with caretakers. So then the images that we developed with Hesperian developed here, very self-explanatory. You see the woman on the left cleaning the mat with soap and water. The middle picture is a woman putting a tablespoon of chlorine into a pot of water. She can then use that to sanitize the mat after it's been washed, and also use that chlorine solution to sanitize the toys. The picture on the right is showing her dunking the toys and cleaning the toys in the chlorine solution. And then our final objective, let's see here, is actually objective 5, apologies, not objective 4, but it's that caregivers will keep household livestock, such as chickens or rabbits, in pens or cages to keep animal feces away from children. So this picture, the last one here, is showing the traffic of dirt. I think this is familiar to many. On the left-hand side is an aerial view of the urban slum. So you see the dirt from animals and chickens and the people, kids, being tracked all around the home. At the bottom by the stream, the aerial view is showing a child playing with a dog. And then if you look to the right, that picture is kind of expanded or blown up, showing the child sitting there with the chicken and putting their fingers in their mouth. And so really clearly illustrating for mothers and caregivers how this dirt from animals gets into children's mouths and into their intestine, and thus causing perhaps diarrhea or bothering the intestine enough that it contributes to stunting. So this is our the main point that we have in this lesson 6 on environmental enteropathy. And so now I think that brings us to the end of our presentation. We can open it up for questions. I know there's some that have been shared in the chat box that we'll address. And if you have additional questions, I'm not sure, Patrick, if they'll have mics or continue to write them. And then we have a few discussion questions. So thank you.
Okay, I guess with this size group, let's just go with typing only. Cindy, do you want me to read the first questions out to you, and then you guys can take a crack at them? Or
Sure.
do you want to read them?
Yeah.
You can see them. Okay, I'll read them. So Christina Beal asked, she said, how long was the curriculum development process for this effort? And additionally, are the images used in something like counseling cards?
Great questions. So Phil just stepped out. Hesperian might be able to answer. I know the curriculum development was about, I think, a 4-month process of back and forth. I joined in the middle of the process. So Hesperian, correct me if I'm wrong there. And then are the images used in something like counseling cards? Right now, we haven't done anything else with them except use them in a care group flip chart. So they're in both a module with fairly more details on each topic, and then they're in a flip chart for the care group volunteers to use when they make household visits. So similar to a counseling card, but all together in one flip chart. I hope that answers the question.
Okay, great.
Yeah.
I think so. Christina wrote in, thanks. Okay, I had probably a quick question. Do you refer to how old the baby is who's getting treated water? I was assuming the baby is over 6 months, but we don't want to confuse people thinking that they're supposed to give water to a young baby. So I just had this little momentary knee-jerk reaction.
Yes, yeah, Mary, we did. I'm sorry, that was a misprint, a typo when I said 0 to 23. It's actually.
Okay. Let's see. Let's move on. Suzanne Furman said, it was mentioned that there were no existing materials in the context. Wasn't there anything existing that could be drawn from? Did you work with the Ministry of Health to ensure alignment with other materials they might have? And she said, does Hesperian do any work with photographs rather than images? So,
shall I answer the first piece and then Hesperian can? Sorry.
Yeah, go for it.
I'm sorry, Mary. Okay. Yeah, I mean, we did coordinate very closely with Ministry of Health in Kenya. We did look at their materials. We did talk with them, and after looking it over, we concluded that they didn't really have anything that would fit with this particular kind of activity. And I think further down, Christina made the question about posed the question about what about the UNICEF, IYCF materials. It was the same thing. We looked over those as well. They're great materials. They did not seem to fit what we were talking about. So we concluded that we needed just to start with other images. And Clementina can probably speak better to this, but we were in close contact with Ministry of Health the whole time about the images and about the whole project. So yes, and maybe folks from Hesperian.
Yes, sure. So this is Sarah. And in terms of one thing that I didn't mention in the presentation, although there's a link to it, is that we do have a very expansive image library of 12,000 images that are used in our publications, and we are actually actively trying to see if there's ways that we can expand that library to include other people's line drawings as well. Precisely because it makes it easier then to adapt rather than to create totally new images. One of the challenges is that I think all of us in this community health world we don't have as many urban images as we would like, and so one of the things that we were really excited to do with this project was to develop images that could work across both urban and rural settings, which is, I think, an area where all of us need to be continue to expand. But we do have an image library that would be a starting place for anybody wanting to illustrate materials, because you can either just repurpose the images that are there, or we can help you edit them to make them work for your purposes. So that's one thing that I did want to say. Someone also asked about whether or not we do photographs as well as line drawings. We for our publications, our expertise is really in line drawings. And the reason that we opt for line drawings is because they can read more cross-culturally and are more easy to adapt for different settings than photographs as a media. They're also cheaper to reproduce, and they're easier to colorize when you want. So for a lot of different reasons, we find that the line drawing illustrations are more effective than photos. But for a very localized project,
great, thanks, Sarah. So I'm going to try to group a few of these questions because it looks like several people are wondering how the heck you get children to stay on the playmat. And what about situations where the chickens usually roam to find their own food? So that was Jennifer Marcy introduced that topic. Erica said something about chicken coops and cannibalism, which I don't understand. Is that chickens eating other chickens? And Sarah Bowler said the interesting thing is the EE increases when the child is introduced to other foods rather than breast milk. That's also when they're crawling around. A critical stage in development as they start to crawl and explore. Did you consider playpens rather than mats? I think it would be difficult to keep a little crawler on a mat. At the UNC conference, there were some RCT presentations on playpens. And I know this is, yeah, I think people are saying the chickens ate each other. I'm getting some. Anyway, this is like a whole topic, so we probably won't be able to go completely into the mats versus the playpens kind of thing, but we'd love to hear a little bit why you guys opted for mats and how did that work?
Yeah, I mean, I think the short answer is we really don't know. We've been looking at a bunch of other projects. We tried to get materials from the Zimbabwe project. I spoke with Save the Children about their Ethiopia project, but we couldn't get a lot of details about what they were doing besides using playmats. And when we talk to people in the communities, it's a real common practice in Kibera anyway, as far as we could tell, to put a child on the floor and let them sort of play around on the floor. The whole business of keeping, I mean, as a parent, I know the whole business of keeping a kid on a mat is a pretty big challenge. So it's something that we're not sure about, and we're hoping to look at more closely, and frankly, we're hoping that maybe some of the participants here might have some input in.
Great, thanks. Oh, and Erica from Land of Lakes also said, have there been rigorous studies of the impact of including baby wash components like this in livestock programs, for example, RCTS? And I believe they are beginning to do some, but most of them haven't published results yet, and Tom just said the same thing. Okay, but they decided to go ahead and try the intervention, in practice. We decided to intervene with what seemed helpful in improving baby wash in the meantime. So you guys had some discussion questions you wanted to pose to the group too, is that right?
We do, Mary, and part of this has been already addressed. Jumping here to number 3, since we were just talking about it, if anyone here joining the webinar has materials or lessons learned on environmental enteropathy, we're really hungry to have that and learn from you. So if you can share, as we said, we're at the beginning. We're just beginning to implement this project, so we don't have results to share. And the issue of playpen is very interesting. So if anyone has something, maybe they can write it in the chat box, or we can address, as Tom said, perhaps another webinar on this topic. Yeah. So that's number 3. And then one of the other discussion points that we wanted to look at was urban care groups. So again, we're just presenting some of the advantages and disadvantages or challenges that we find in working with care groups in the urban setting. So we wanted to hear if anyone else has experiences or lessons learned from other urban care group projects, or anybody contemplating an urban care group project.
Yeah, I haven't heard about too many urban care group projects. People ask me a lot of questions about them, but yeah, go ahead.
Okay, yeah, so we'll just throw this out, and then the second one was we just thought we would talk a little bit more about how NGOs or PDOs could partner with Hesperian on future curricula development, which I think that they did touch on that topic already as well. So I guess we can leave it open to see if there's any more questions, or if any of the other presenters want to jump in or add any points.
Can I just ask, Altrina is saying that in Haiti they have urban care groups. Altrina, can you tell us anything about that?
Maybe, could we give her a mic? Patrick? He says yes.
Do we have the capacity?
Yep, he's working on it. Okay, Altrina.
Can you hear me?
Yeah.
We can hear you. Yes, we can hear you.
Okay. You can? Okay, great. Thank you. This was a very interesting presentation for me because we are working in some urban areas in Haiti, and so seeing what you're doing in Kenya and Tanzania and Uganda is quite exciting. And also the materials that you've developed. So thanks so much for sharing that. Some of the challenges that we faced in Haiti are very similar to the ones you presented here. Finding locations for the care groups to meet, we found that churches in the community were really happy to allow us space, and they allowed us space free to host the care groups. And so the women were very willing to come to those areas. I know, as you mentioned, about meeting in open areas in the community that may work in rural areas that doesn't work in the urban areas because of such crowding and so on. So the churches were very good venues. And then also having to meet on weekends and after hours because urban women are working. We also encountered that, and our women are meeting like on Sunday afternoons or Sunday evening, or not evenings, but late afternoon, and other times that they find most appropriate. So you have to adjust your staff schedule to fit those weekend kinds of things to be able to meet with that. And I think that's the most I can contribute at this point on the urban care groups.
Thanks, Altrina.
That's very interesting about churches. Thank you.
Yeah, I'd just like to point out briefly that we are also partnering, Feed the Children is partnering with partners of the Americas in Haiti on care groups work. Our zone is rural, but we work very closely with them, and we're learning a lot from their lessons there.
Wow. Well, thank you so much. It looks like there's lots of great comments coming in on the in the chat board too. I'm wondering if there's some of those I need to read out. Hearing a lot of people are working on these and related topics. Anyway, I wanted to really thank you all. It's been very exciting to have you. I just have a few more announcements and updates to share as we close out the meeting today. I wanted to update you guys about the Ebola virus care group module and some care group publications that have recently come out. And if anybody else has announcements, there'll be a spot for you too. The Ebola virus disease care group module is so close to being finished. It's just in the final stages of copy editing. I was hoping that we would have like all 9 lessons ready to share today, but very, very soon, and stay tuned. The first 5, which are actually the last, or is it the last 4 or last 5, that were designed for people dealing with active Ebola virus in their communities, were published quite a while ago. But the first 4 are related to prevention, and it's available, Jean. The ones that are already ready are available on the FSN Network website, and I think they're also up on Care Group Info. But just email me and I'll send those to you. Mary, you've got I think you have my email. Okay, let's see, and maybe Tom can pop the link into the box there. So Tom mentioned this recent care group publication with Christine Marie George and et al., including Tom. And there was an exciting journal club presentation about this. And I do have that link. So that was really fun and well attended and great discussion held recently. I put that link into the box for you all. And we had some other publications in Global Health Science and Practice from the September edition. The editorial was about was related to care groups and participatory learning groups, I think. And then there were two articles with Henry Perry as the lead author and some of us as the co-authors. Care Groups 1, an innovative community-based strategy for improving maternal, neonatal, and child health in resource-constrained settings. And Care Groups 2, summary of child survival outcomes achieved using volunteer community health workers in resource-constrained settings. Okay, Tom put the link in for the Ebola Care Group module. That's great. So does anybody else have any related announcements? Let's see. Tom says, close to finishing the Ebola barrier analysis compendium as well. About 3 more pages to edit and then on for format editing and review. So that's great. Any other announcements, anyone? Super. So people can activate their mics if anyone else wants to say something as we close out. No? Well, thank you everyone for attending and your participation, and a special thanks to Cindy and Phil and Hesperian and everybody at Feed the Children for pulling together this fascinating presentation. You all have a good afternoon or evening.
Thank you, everybody. We really appreciate it. It's been...
Yeah, thanks, everyone. Bye-bye.
And a special thanks to Clementina for bearing with us out there and so late in the evening. Thanks again.